Yeah.
My talk today is how and when to transition the pediatric patient. I have no disclosures, and I suspect there will be some time at the end to ask additional questions as well. So we're going to talk about transition and transfer, understanding the scope, developing a framework, and hopefully you'll come away from this with some resources to really support you in this work in your own practice. So just a little bit about me. So I came to transition really from Craigslist. So when I was trying to decide if I wanted to be a doctor, I answered an ad on Craigslist to be a PCA. And it turned out that this young woman had SMA. She actually was a Gillette patient, and that was my first exposure to Gillette. And through this experience, I really learned a lot about transition and how difficult it was for her to find the right doctors and for her to get the right care as she aged into adulthood. And because of this, I went on and did an internal medicine and pediatrics joint residency where I worked in the Twin Cities and got to see patients at all of the different hospitals in the Twin Cities and see how they flowed from one system to the other. And ultimately, as I went through my training, I knew I wanted to see really complex patients because they were the most fun. I wanted to help families as they were making these transfers across different systems, and that's what led me to Gillette. So we're going to talk through kind of a whole bunch of things as it relates to transition, but first we'll start with who. So who's transitioning? And really everyone transitions. This is a universal experience. Those patients that have no chronic diseases often have to transition from one primary care doctor to another primary care doctor. And then as they add on conditions, it can get a little bit more complicated. So if you look at the literature around transition of care from pediatric to adult, there's certainly some around these single common diagnoses, like how do you transition ADHD care? And this is a common one that if you look at adult internists, are they going to prescribe the Ritalin and things that the pediatrics prescribed? How do you transition asthma in an effective way? Or how do we manage learning disorders as patients age? Then there's a group of patients that are medically complex and they're going to live independent lives, maybe with some support here and there, but ultimately will really have the ability to make their own choices and around this, they'll have very specific skills that they're going to have to learn. So in a patient that has type 1 diabetes, for example, like they're going to have to learn how to do their own injections and count their own carbs and call into the pharmacy to get their own medications. And this is actually where the bulk of literature lives around transition, is what are all of these skill sets for these patients that have either single diagnoses or kind of a medically complex diagnosis that kind of permeates all of their different systems. So that's where the bulk of the literature lives. Where the bulk of my practice is in this medically complex, will not live independently for the most part. So those patients that have severe cerebral palsy, those that have trachs, feeding tubes, cognitive delays that go along with it. And that is a field that is developing, and there's more and more literature coming out every day. And we're finding that lots of the resources that are out there don't quite fit this patient population. I'm lucky in that a lot of my practice is this medically complex, but I get a good flavor of working with folks that have spina bifida or muscular dystrophies that do have the cognitive abilities to live independently. So I get to kind of take what I'm learning from the literature on both sides and apply it across the spectrum of disease. When it comes to the who, transition is not something that one person can do by themselves. So I like to think about transition as really being a team sport where we're relying on multiple players. So I'm here in the complex care transition clinic, but I can't do this alone. I get to really utilize this vast team, both at Gillette, outside of Gillette, in medicine, outside of medicine. to really kind of meet these patients' needs. Patients, parents, primary care doctors, subspecialists, neuropsych and psychology as it relates to kind of mood disorders and things that can come along during the transition, neuropsychology in terms of testing for guardianship purposes. Our clinic RNs are awesome. And oftentimes I learn that the RNs are doing a lot of this transition work in the triaging they're doing for patients along the way. We have care management in our system, and many care managers are out there in primary care clinics that we partner with. Our therapists are amazing at really helping set goals in therapies around transition related things. Therapeutic rec is crucial. Social workers are there to help with all of our insurance issues that come up, guardianship related things, as well as the social supports that are necessary for this to go smoothly. And then often under recognized, but school is also kind of doing their own transition, and how can we better partner with them as well? I'm sure I've left people out. A little bit of transition together. So what? Oftentimes when people are thinking about transition, what they're thinking about is actually transfer. And transfer is just changing the provider. So in the context of this talk, it's really talking about transitioning from pediatric to the adult provider. And that's just one little piece of transition, is finding that new provider. What I like to think about transition is really this planned process around skill building and empowering patients and families to navigate the adult world. We know that adult medicine is so much different than pediatrics. So how do we help families and patients be able to know how to navigate that? What are those unwritten rules that no one tells these families about how things are going to be different on the other side? In our Gillette Transition Committee, we've been trying to kind of figure out how do we kind of make a schematic of what transition is. We know it's just not, finding your adult gastroenterologist or your adult PMR doc. It's so much more than that. So this is a prototype. We're still, working on how does this kind of fit together. But who my care team is just a piece of this puzzle. We need to figure out all those pieces around where will I live and what are the resources and things that need to be in place for me to be successful in that environment. What am I going to do? For many of my patients, they've been in school and then maybe did a transition program, and now there's not much out there for them. Are there day programs that they can get involved in? Are there other social events that they can do? What sort of skills around school, job training and things can we get to allow our patients to have these full, robust lives? And then, of course, all this is related to how are we going to pay for things? Are they going to get a job? How does that affect the benefits and waivers that they're eligible for? How do we kind of look at this holistically? So why? If we look at just kind of why this has become a problem, it's because pediatricians are doing a great job of keeping patients alive. So this is looking at life expectancy over time for folks with Down syndrome. So as recently as the 80s, the median survival for Down syndrome was 10 years old. Now, if we look up, it's up into the 50s. So we've created this robust explosion of life expectancy in many diagnoses. And along with this, we're finding that now there are more adults with these childhood onset diseases than there are pediatric patients. And unfortunately, education and training has not kept up with this explosion in life expectancy. So our adult colleagues don't always feel as comfortable taking care of these diagnoses because it's not part of the fabric with which we're training folks. So this is the life expectancy curve for cystic fibrosis. And I just like this because it very clearly shows that as we're making these adjustments to protocols around caring for these patients, you can see that there are clear benefits long term into those changes. Sickle cell disease, similarly, in terms of life expectancy. And then this is the opposite direction in terms of our patients here with cerebral palsy that is severe. This is survival of 4-year-olds who do not lift their heads when in the prone position and are tube fed. So you can see even here they're having a life expectancy increase as well over the last several decades as well. So first and foremost, this work is important because it's all about safety. So we know from the literature that during this transition period, there are more hospitalizations for these patients. There's more delays in care. There are drops in medications. And there's a lot of mental health pieces that go along with this. So this was a quote by a mom that came to clinic and saw me, and her daughter had a near drowning event and now has severe anoxic brain injury. And this is what she said. So her daughter was 12 at the time of this injury, and now she is in her early 20s. And she says, "I feel like transition is scarier than when we were going through the trauma of the initial accident. At least then I had a team of doctors around me that I knew I could trust. Now I feel like we are all alone. I've never been so scared for the safety of my child." And this is not the only quote that I hear. I hear this time and time again from my patients, is that I am scared. I don't know where to turn. I recently had a mom tell me about her experience with her now 20-something-year-old daughter, who weighs 50 pounds. And she went to the pediatric ER and was told, "We don't see 20-something-year-olds in this ER. You need to go to the adult ER." She went to the adult ER and they said, "We don't see children that are 50 pounds, or we don't see young people that are 50 pounds. I think you'd be better served in the pediatric ER." And she wasn't able to access care. So this safety piece is true. It is simply unacceptable, and we need to be open and think about this patient population very closely of how we can best serve them. Secondly, this work is important because these are all of the tasks, or maybe a fraction of the tasks that families are having to navigate as they go through transition. So we took a survey of our families to come up with what are all the things that have to happen during this period of transition. And this is what families came up with, and I'm sure there are things that are missing, but families need support during this. This isn't something that one provider can take on. It isn't something that one family can take on or the county care worker can take on. This is a massive undertaking that families are doing, and we all have our piece to play in this. And lastly, this work is important because it's meaningful, it's valued, and it gives me so much joy to be able to be with families during this path. So I love it when patients come back and say, "Oh my gosh, we found a PCP that we love. She gets us." I had a young man who wanted to move out on his own, and we kind of started talking through, like, how would that even happen? And we decided maybe the first part is that we need to have a bank account so you could actually make a payment, a rent payment. So he came back to clinic and was so proud that he had opened up a bank account. And then we slowly chipped away at what are the next steps. Patients of mine that are excited to study and to go to college and move into the dorm rooms and achieve those dreams that they really sometimes felt like weren't available to them. And then, of course, I always feel proud when I have a family member that can say this, now that you've helped me with this piece, I can go back to the Capitol. I have time to be able to advocate for patients or for young people like my son who needed some added support. So this work is so thrilling and exciting, and it's hard. But when we do it as a team, it's possible. So where does transition happen? So this is happening all over the place. We often, I think, at least in medicine, get kind of stuck on, okay, we need to do this transition in the clinic, and we got to find them a new clinic to go to, um, and we kind of get stuck in this realm. But at the same time, we're talking about transitioning across multiple different areas of their lives. Insurance companies are going to change, and how does that affect all of this? Home life might change. Are you going to move to the dorms? Are you going to move into a group home? And how do we use those experiences to help us with the transfer of other specialists to make it work for these patients? School's going to change. Are you going to go through a transition program? Are you going to go to a day program after that? Are you going to go to college? Are you going to go straight to work? And how can we make that part of your life work as well? And then a project I'm working on right now is to really think about inpatient transfers as well. So we have a group that meets of med peds hospitalists at all of the major systems in the Twin Cities to really talk about, how do we make this inpatient transition happen as well? Because this needs to happen kind of in tandem, and these are all overlapping. So really thinking broadly about where this transition is happening and how it affects different things is crucial. So when? So I brought this up or alluded to this before, but really starting in the early teen years is when you want to start thinking about transition. And in the world of transition medicine, which is very small but growing, there is now a fellowship program at the University of Rochester in transition medicine, which is super exciting. But in the field of transition, if you're going to do any research, the place you should start, or as you're kind of thinking about how to build this into your own practice, is this website called Got Transition. And it is a federally funded program through the Maternal Child Health Bureau that has developed all of these amazing tools for you to implement directly into your practice. So you basically can go to this website and choose what type of practice you have. And it's great because it thinks holistically about transition. So if you're a pediatric only system, it has a whole set of processes that you can work on for that. If you are a pediatric and adult system, so med peds, family medicine, what might that look like for your practice? And then they also, on the other hand, have the adult component of transition. So what's really nice is whatever type of practice you have, you can go there and really it walks you through, what is your policy around age limits? What does that look like? How can you implement that? You can take a survey of how you're doing in terms of transition, and that can help guide you as to the low-hanging fruit that you can start implementing in your practice as a system to start fundamentally making a change and making this better for patients and families, and importantly for yourself as a provider too. There are these 6 core elements of transition that Got Transition talks about. So policies, tracking and monitoring, measuring readiness of patients for transition into adulthood. So like I was talking about those young people that are going to live independently, there are readiness questionnaires you can use in your practice to be able to identify those things that you should spend time on as it relates to transition. So for example, what does it take to order your medications? Can you do that? Who's doing that for you? And that can really help goal set with patients. Developing medical summaries for patients that they can use when they are going to meet new providers, actually transferring the care. And then of course, thinking about transition completion, which I disagree with this number 6 here in that it says age limit 18 to 23. I think transition goes well into the 30s, maybe even longer. I consistently get patients who are referred to me in their 30s and 40s that are still working on this transition. piece. So I think we have to think broadly about how long this transition happens. The other thing I think Got Transition really does well is thinking about that this isn't just a pediatrics problem to start talking about transition early and doing all of these things to get someone prepared. It is, I think, completely unreasonable for us to think that at 18, a pediatrician who has done their job, that this child can just, now young adult, can just flourish in the adult system in the way that it is set up. And that's just simply not true. The adult system is not set up for our medically complex patients. Probably not even set up for our, healthy adult patients to truly access care in all of its complexities. But we also need to look to our adult colleagues to take these patients and help them through this process. It's different, and in some ways, we both do things great in terms of how pediatrics approaches things, how adult medicine approaches things, but there's not often a lot of crosstalk between us in terms of, what we can learn from each other about how we do care. So I just want to impress upon everyone that this is a team sport, and both sides, pediatric and adult, really have to think about how we exit pediatrics, but how we enter adult care and help that be successful. So in my own practice, what I actually do in terms of kind of age limits, because most people are wondering, like, okay, they say start transition at 12, but that seems icky. Like, am I really supposed to say when a patient is 12, like, my age limit is 21 years old. So in 9 years, I'm going to say goodbye to you. And that's what I'm supposed to talk about when a patient is 12. So this is kind of like how I kind of conceptually think about what I'm doing at each step of the way. So when patients are kind of in those early teen years, I really try to focus on what are those abilities that they have that are going to carry them through into adulthood. So for my patients that have spina bifida and are going to want to go to college, kind of what are those pieces that we can start now when they're 12, 13, 14 to get them prepared for college into the adulthood. So one of the simple things, I recently helped a young woman who was going off to college for the first time, and she had never even done a slumber party, and she was going to go live in the dorms for the first time. So thinking about, what are those developmentally appropriate things that 12, 13, 14-year-old kids are doing that kind of prepare them for experiences of living independent lives into adulthood, can we implement into those early years? So like encouraging families to think about, how might we be able to do a slumber party with friends when they're in their early teen years, when they have all this medical complexity? Is that possible? If it's not, why isn't it possible? And how can we make it possible? And then really 12, 13, 14-year-olds can start doing a lot of things, cap themselves, give themselves their own insulin. I like to have these children start to do parts of their visits without the parents in the room, to start talking about things that maybe they don't feel comfortable talking about in front of their parents. And when we look at, that's general pediatrics, kind of 101 is, when are you going to start to have that 5 minutes of the clinic visit that is reserved for without mom? When it comes to our patients that have medical complexity, this very quickly gets pushed off. And there are some of my patients who have never, ever had a part of a visit where their parent isn't in the room. Even those patients that have guardians, I think it's important into adulthood to think about, is there a way for me to communicate and have part of the conversation without their care team in the room? In the kind of middle teen years, really building on those healthcare navigation skills. So how I work with families on this is when you're going to check in at the doctor's visit, instead of you sending Johnny to go sit in the chairs and you'll go do the check-in process, bring him up to the counter with you, and let him hear what they're asking about. And then when that feels like, okay, he's kind of got a feel of that, like maybe Johnny goes and stands at the counter and you stand a foot behind him. And you're there to answer any questions that might come up that he gives the big eyes and I don't know about, but you're slowly kind of building in those skills around taking responsibility and independence around those pieces. Also, from a systems standpoint, and this is something that I'm trying to kind of think about how we could build this in, is how do we start to have the entire system think in this transition mind frame? So is there something in your call center or in this way of asking or prompting families to include the young person in the conversation? So if someone is calling from Gillette to schedule an appointment, is there something that we can put in there to say, when they're 16, always ask mom to, can we put your child on the phone on speaker? As a way to just get them used to understanding what are the questions that are getting asked of my mom when she's calling to make the appointment, and whatnot. Around this kind of middle teenage years, I start gathering information about age cutoffs for providers. I often try to partner with my patients on this age cutoff question of prompting them of, at your next appointment with Dr. Sinner, ask her kind of, when will she keep seeing you for? Many patients will not want to do this. In fact, I've been told many times of, if I just don't ask the question, then maybe we can eke out another year or another couple years, and she won't notice how old I am. So many families will really try to avoid it because they love their pediatricians. I start having conversations around guardianship around 16. Really, neuropsych testing and the diagnostic testing around this can't happen until they're closer to 17 to 17 and a half, and the paperwork doesn't happen until closer to that 18th birthday. But I want them to be thinking about this. And then really starting to educate around, what's the adult healthcare system like? What can be expected of them? As they get a little bit older, I typically, in general, really like to start focusing on, can we find you an adult primary care doctor? And many patients are really worried about giving up their pediatrician because they're so great. But I like to kind of start with thinking about who that adult primary care doctor is, because in the long run, the adult primary care doctor is really the person that's going to take over my job as kind of manning the ship of seeing all the medical complexity. And what I think is most important in regards to this primary care doctor, there's a couple things. One, the patient has to trust and fully feel like this adult primary care doctor is there for them. They do not need to be the expert in cerebral palsy. They need to be a doctor that they trust and a doctor who is willing to ask questions. And I am happy to give my cell phone number out to any adult primary care doctor so that if they are seeing a patient and not quite sure what to do, they can always reach out to me and we can kind of talk through a plan together. Equally important to making sure that this family feels comfortable with this primary care doctor is that this primary care doctor feels supported in caring for this family. I'm so lucky to be at Gillette where I have resources and time and get to see this over and over and over again. So when I have someone come in that has a G-tube issue, I have tons of resources to be able to take care of that. Our adult primary care doctors don't have that same luxury. So I want to make sure that as they're taking on these patients, that they have, one, a means to reach out to me and to feel comfortable that Gillette is going to be there for these patients. And you can always ask for assistance or some guidance or just like you want to talk through a problem together. We're here for that. The other thing that's so important is making sure that this adult primary care doctor can be successful. So when I think about transition, it's all about, as it relates to the care team, it's all about creating a team that can work together to take care of this patient over time. Now, if we set up a primary care doctor and then all of their subspecialists in 6 different healthcare systems and expect this primary care doctor to flourish, it's just not going to happen. So when we think about adult primary care, I like to think about, okay, how can we find providers for the subspecialty care that are going to work well with this primary? Are there resources in the same system so that if there are questions, it can be an epic message instead of calling to talk to a scheduler to have someone call you back? How can we just make that easier for adult primary care? That's going to make them a more engaged provider, and it's going to lead to better care for their patients. I like to try to think about transitioning 1 or 2 specialists every 6 months. That's like my goal. It doesn't always happen. Many times it's much slower than that. But I think that's a good framework for families to think about. I don't want like the rug to get pulled out from under you and no providers that you know are involved in care anymore. We want to do this in a stepwise, controlled fashion so that it's safe for your child, but also you have the ability to kind of slowly try 1 or 2 providers out at a time. I continue to transition specialists into adulthood. And one of the things we're working at is trying to kind of like, how do we track this and check in with patients over time to make sure things are still working? So I talked a little bit about how we do this, but I thought it would be helpful to kind of talk through a patient case. So this is a 26-year-old with spastic quadriplegic cerebral palsy who presented to me for support with transition. And this was actually because transition and transfer of care had not gone well. So this patient has a trach and a ventilator, gets recurrent tracheobronchitis. They have a G-tube and chronic feeding intolerance, a seizure disorder, and intermittent dysautonomia storms, which can be quite severe, chronic pain, hydrocephalus with a VP shunt, spasticity with a baclofen pump. So I'd say this is kind of like my bread and butter patient that I see all day long, but it certainly is not bread and butter, I think, for probably most people that don't work at Gillette. So this was the doctors that this patient had. So he had a primary care doctor who actually is med peds and the family loved. So I was like, oh my goodness, score, this is amazing. He had a neurologist, had adult primary physical medicine and rehab at Gillette, had a dietitian at Gillette, had an eye doctor and a neurosurgeon at Gillette as well. So if we kind of troubleshoot what's going on here, this is kind of my initial visit is always trying to figure out, okay, what's the lay of the land? And how I do this is I really march through the problem list to see, okay, do we have the right providers in place here? So for the trach and ventilator, he did not have a pulmonologist, nor did he have an ear, nose, and throat doctor. 2 things that I think are crucial for this device to make sure that safety is there over time. He had a G-tube and feeding intolerance. He had his dietitian, who was awesome, but who was going to manage this G-tube over time? He had a seizure disorder and his dysautonomia storms and had a neurologist who the family trusted and felt was a good fit for them. So we didn't have to worry about that problem. Chronic pain. So this family actually had met our palliative care doctor, and they said of all of the doctors they had worked with in this patient's kind of later teenage years and whatnot, this was the person who had actually fundamentally changed his life the most. That someone was focused on the chronic pain and really thought about how life could be instead of how life is. So they really, really wanted a new palliative care doctor who could continue to think about his care in that perspective. He had hydrocephalus in the VP shunt, which Dr. Song was managing, and then the spasticity managed by Dr. Shu, and the baclofen pump managed by Dr. Song, should there be any surgical intervention. So with that, I kind of developed this problem list and identify those areas where we need to find someone. So I said, I think he needs a pulmonologist, ENT, gastroenterologist, and palliative care. And I create this document for patients when they're coming through my clinic of kind of, who were you getting care with before? What is the adult provider or transition plan around this, including in here specific age limits where that's appropriate, so that kind of we can get a bigger picture of what's going on. This is really helpful when a patient is like 16 and I'm able to draw this out of, okay, your primary care doctor is going to see you until you're 19, and urology is going to see you until 18. Your neurologist will see you till 21, PMR till 26. And suddenly, when you start to see it like that, this idea of transitioning one or two providers every 6 months or so, it kind of lays out how you can do that in a stepwise fashion. And what I've found for families is when you kind of lay it out like this and they can actually see what's going on, it helps them understand that we're not just going to pull the rug out from you. We're going to kind of find threads of providers that can continue to see you for longer and try to kind of slowly stepwise work through. So this has been very helpful for my own practice. I'm also trying to figure out, and if anyone has any ideas, I'm open to it, of kind of how do I send this out to all of the providers that are involved in their care so they can understand what everyone else is doing. So still working on that. I typically will fax it along with their note to the providers, but still trying to kind of figure out how can this be a little bit more interactive. Then the next step that I do for patients is when there are multiple providers involved that we need to figure out where they should go. So in this patient, you can see here on the left side, specialties. So for them, we had identified ENT, palm, GI, and pain and palliative all needed to get found, as well as neurology, which comes up later. And then what hospital is associated with where they would get their care. So I like to think about typically the best care is when you get as many specialists within the same health system as possible. So in the Twin Cities metro area, typically this chart looks like Allina, Health Partners, Fairview, University in terms of the health systems that are involved. And then I walk through and kind of fill this form out for all patients. And we typically set up a different visit to just kind of walk through this form. So, for example, if we were to look at Health Partners, for example, most of my patients with medical complexity that are getting care at Health Partners are going to go to Regions Hospital for their care, being that one is where typically their most complex patients get shuffled to. And then within that, I start to draw out a picture of where this care might happen. So ENT, pulmonology, GI, those might all be within the specialty center. So kind of this could all happen in one building. That's what that would look like. But if you chose the Allina system, they have kind of different supports that are in place around getting a care with some private groups that contract with their system and how that might look. Every system, patients and families typically have some experience with around whether, yes, they want to go to Allina or university, kind of where those pieces fit. Some of it is insurance driven. Some of it is just distance from home, comfort, other experiences that they're hearing folks talk about. Suffice to say, there's no one system that I say is the best at this. There also are too many patients to go around. So I think that we can create a safe an effective care plan, no matter what system or what hospital our patients are going to choose to get their adult care in. Many of our patients will get a subset of their care at Gillette long term, but we are primarily a pediatric hospital. So we are really just a supplemental component of our patients' care. So I typically will present this to families and then say, noodle on that for a while, talk to other people, and then kind of we'll come back and reconvene, and we can kind of talk about where to go. The value of this is really kind of thinking about giving family choices, because often when it comes to transition, families feel like they don't have choices, and they do. We're really fortunate in Minnesota to have great healthcare systems that can provide excellent care to patients long term into the adulthood. The other nice thing that for my patients who maybe don't live in the metro area and live in greater Minnesota is thinking about those places where they might now be able to get care closer to home. So much of pediatric medicine is centered in the metro area, but there's a lot of subspecialists that are adult that practice in more rural areas, at least compared to pediatrics. Still a void and an access issue, but there are options for patients who previously always would need to get an ambulance ride from their rural community to the Twin Cities to maybe stay closer to home for their more simple acute issues. So maybe it's a simple UTI that needs some IV antibiotics. You actually might be able to go to your local hospital and get that care. And really trying to chat with families about some of the advantages that come along with moving to the adult system. Neurologists, there are more of them that are in greater Minnesota than there are the pediatric neurologists, for example. So really kind of thinking for our patients in greater Minnesota, or in the case of my own practice in North Dakota, South Dakota, Iowa, Wisconsin, what different doors and opportunities are open to them as they age into adulthood. So for this patient, they actually chose to go into the Health Partners system for a myriad of reasons, but we were able to find an ENT, pulmonologist, palliative care doctor, and GI doctor within that system that we transitioned to over the course of, it was about 15 months that we made all of these transitions, kind of stepwise, slowly building, and has now had a couple of admissions at regions as well. And this team seems to be working. I'm still following the patient, and I typically continue to follow patients until we have achieved 4 things, I tell families. So how I run my transition clinic is I will continue to follow you until we have a doctor or provider who can care for each of the problems on your problem list. So if we have a trach, like we have someone who can troubleshoot the trach and everything that's going on with the ventilator, and I won't discharge you. This is all voluntary. They can decide to discharge from my clinic whenever they want, but I won't discharge them until we have found someone to take care of everything on there, so that you have someone to call when problem number X is acting up. Secondly, to me, it's not enough that we just have providers that are there. If you don't trust that provider that's there, then we have to go back to the drawing board. So the family has to feel comfortable with the team that we've created. I have to feel comfortable with the team that's created. And lastly, the primary care doctor has to feel comfortable with the teams that's created. Once those things are achieved, then I say, I will see you back for PRN follow-up. And then if something changes, your insurance changes and now you can't see half of these providers, you get a new diagnosis and now we need to find someone else. It's just not working. Someone retires. Then you can come back in. We'll do some tune-ups. We'll get you situated, and then we'll go back to PRN follow-up again. the reason I do this is that, one, I love doing this and I want to keep on doing this for a long, long, long time. And if I never discharged anyone to that PRN follow-up, then I would get full and wouldn't be able to keep on doing this sort of work. And framing it like that for patients, and also ensuring them that, I will reach out to your primary care doctor. I will give them my cell phone number. If there are issues, they can reach out to me. That we can really still collaborate, and you still have access to the Gillette expertise if you need it, but we have to try this adult world. And it's been fairly successful so far. We'll see how it goes as it keeps on going. I've been doing this now for a few years. So as you can see, this is a long process. So I've only graduated a small subset of the patients. So we're going to keep on working on it. It'll probably start out with kind of like, we'll do follow-up in 2 years and 3 years and 5 years, and see if we can kind of slowly transition patients away from my care specifically as well. So suffice to say, we got this all situated. Family was feeling really great, and then the neurologist was moving to a different practice that they cannot go to. So now we're back to the drawing board in terms of neurology care. So it's an ever evolving process. But we certainly can make it work. And what my hope is that over time of going through this systematic process, that families are building a framework around knowing what to do when something like this happens, and having the skills to be successful in empowering and navigating the system themselves as well. So really what this all evolves into, we talked about who, what, why, where, when, how, but really what I'm moving towards and what I really am passionate about is I'm one person. And I think I have a pretty profound effect on patients when they come and see me, but there are thousands of patients like this in Minnesota that I want to have a positive impact in. So this is where advocacy comes in, and where together as a healthcare team, I think we can really make a difference. So I just have a couple tools here that you can explore to become an effective transition ally. And hopefully it will help you feel a little bit more comfortable with this patient population as well. So the first one here is a documentary called Crip Camp, and it is outstanding. You can watch it on Netflix, or you can watch it on YouTube for free if you don't have Netflix. I actually just led a medical group panel earlier this week. I had medical students, they watched this, and then we had a panel of folks to talk about kind of reactions and whatnot. This documentary tells the story of disability rights and justice over time, including a good description of the ADA and kind of where advocacy came from. So it's a really inspiring documentary about how important it is to advocate for these for our friends and colleagues and community members with disabilities. Secondly, if you're into podcasts, there's this wonderful podcast called After Effect. And this podcast tells the story of a young man with intellectual disability and autism who is transitioning out of or transitioning into adulthood, and really talks about the interface between policing, resources available for young people with autism, and the cognitive delays as they age into adulthood. Incredibly powerful, very insightful, and just lots to learn about the greater system with which our patients are navigating. When the pandemic started, there was very strict visitor guideline rules, and this, I think, was painful for everyone involved: nurses, doctors, families, patients, but in particular, our patients with disabilities who were adults and were unable to advocate for themselves, this became a huge problem. So we worked with the Minnesota Department of Health to develop this guideline and policy recommendation. You can just Google MDH access to support in the hospital and you'll find this document. It's a PDF. I print it out for all of my adult patients and give it to the families so that they have this at the ready. And basically what this document talks about is a visitor is different than a support person. And if one of our young people with a disability is in the hospital and they cannot talk, they cannot advocate for themselves because of their disability, that this is a resource they can use to say, I need someone here at my bedside for me. We all know that parents of these young people and guardians are able to interpret things that a nurse could never do at the bedside. And this leads to better care for patients. So I give this as a tool for patients to advocate for themselves. Also, with the creation of this, if you look at any of the websites, at least of the big three systems in the Twin Cities metro area, and you go to their section on visitors, you will now see a clear distinction between this is the visitor policy and this is the support person policy. And this can be so crucial for our patients to feel safe in this transition into adulthood, that their needs will still be respected. And if you have a chance, I encourage you all to look at the visitor policies for the hospital in your system and see if it clearly says a difference between a visitor and a support person to make sure that our patients are safe. If it doesn't, this can be an effective tool to bring to your administrators to say, why don't we have this in place? Other systems are doing this. Next, I am the medical advisor on this Project Echo. So we know, just like I was talking about at the beginning, is that adult medicine education is often limited in the amount that these adult colleagues are getting around childhood onset diseases. So the goal of this Echo is to have an expert come and talk about a typically pediatric diagnosis or device, and then present a case related to it to help adult primary care doctors, adult systems really think about those knowledge gaps that are in place. So we meet every other Monday or so and talk through a case. We have a couple coming up here in November. One is about dental care in the adult with medical complexity. The other one is about cervical stenosis in the cerebral palsy patient. So just wonderful wealth of knowledge and sharing about how do we do this care better? What are some of the knowledge points that you never learned? We are welcome to have requests for specific topics or cases that people want to present. And you can just sign up for this at the Minnesota Medical Association website. So if you just search MMA Transition Echo, you'll get right to our webpage and you can sign up for those. We're really excited to have had a very successful launch of this. We've talked about drooling, we've talked about ACEs, we have just had a childhood cancer survivors and monitoring and surveillance after that. So it's just been so fun. It's been a good group of folks from greater Minnesota, the metro, and even outside of Minnesota. So it's been just wonderful. I will offer myself up to anyone that has questions or wants to get involved. So you can certainly reach out to us. We're happy to help both clinically, or if you have ideas or thoughts or questions, I'm happy to do that. I also encourage everyone to ask about transition-related education at all of your local, national conferences of this is what I want, this is what I need, to really kind of spread the nature and learning around transition. And then lastly, we are doing a lot around transition and advocacy. So if you're ever interested in getting involved, you can always email me, and I'll add you to our list of folks. We'll be hosting a transition summit in March, which will be all about how can we systematically think about doing transition better in Minnesota. So my takeaways are, you're not alone in this work of transition. I'm here with you. There are many people across Minnesota that are interested in this work. This work is so rewarding, and being with patients during this journey is just a joy. And then as you're kind of thinking about, oh my gosh, this is a lot, there's tons going on, I just encourage you to work closely with your patients. And this doesn't need to happen on your nights and weekends to help patients with this. Being stepwise, having frequent visits with patients is absolutely okay. So if that means that you're meeting with that patient every month to work through slowly each of their problems and each of their systems, that is totally reasonable. And I think the joy of telemedicine that many of us are still doing is that it makes this work even more powerful and attainable. So thank you very, very much. We have a few minutes for questions. I think that's all.
All right. Thank you, Dr. Bahr. I don't see any new questions in the chat, so I think we will probably wrap up since we have emails available. So that concludes our program overall for the day. I want to thank everybody for attending today's conference. Definitely please complete the conference evaluation. There's going to be a QR code that's going to come up on the screen in just a minute. And so you can scan that. We appreciate all of your feedback, and you're going to receive a follow-up email later on from Gillette CME that's going to include your certificate of attendance and what you need for that. But definitely please do the QR code, give us your feedback, and we thank everybody for your time.